What is going on, everybody? It is Mark and Jarod, lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. Coming at you for our next episode of the Modern Pain Podcast, where we're going to talk about lower extremity neurodynamics. We've had a series of neurodynamics, upper extremity neurodynamics, and now we're moving our way into the lower extremity, but we're going to talk about some dosing and some other topics. But before we do that, let's welcome in our co-host. How are you doing, Jarod Hall?
I'm doing well this morning, man. Other than I mentioned to you, my wife's car got stolen this week, but that's another topic for another time. And it's all good because nobody was harmed in the thievery of the vehicle.
Yeah. Another testament to some poor humans that are out there that are not doing good things. But sorry to hear that, man. Not a good way to have a end of your week, but that's why we pay insurance companies. Hopefully they'll come through for you and do. Or maybe the police will find it unscathed, but you never know. I've had relatives have various issues with and various amounts of success getting that back, but that's why we pay premiums and all that stuff on insurance companies, so hopefully that'll do its thing. But been a busy week for us this week at Modern Pain Care. We've had our complete clinician, we've had a lot of our coaching calls, had some great discussions with our mentees. Folks are signing up for the Lifelong Learning Academy, which we got Nick Rolnick coming in this week. You want to tell folks a little bit about Nicholas coming in and sharing some stuff about BFR, a passion of his, which we're excited to have him come in and talk about.
Yeah, man. Actually, I've known Nick for a long time, and he, as I've known him, he's really become the expert on BFR training and that sort of stuff. And BFR, it's something that's been around for a while. It had originated out of Japan, and Nick got introduced to it and really started going down the rabbit hole of the research. And he's become my go-to guy. So we decided to bring him on, and he's going to do a podcast episode with you and I on BFR as it relates to pain and exercise, and then he's going to do the masterclass with us, which is kind of going to be a general overview of BFR principles and setup and dosing and safety and contraindications and all that sort of stuff. And then we're going to get into a deep dive Q&A session about clinical applicability with all of the members and Nick. And I think it's going to be really good because he's somebody that's pretty reasonable. He understands the research. He understands the value and when it is and is not useful. So I think it's going to be really valuable for everybody. And it's something that I use in clinic. Now, I won't say all the time, but it's something that I use with a decent frequency.
Yeah, I will say I have not adopted it yet. Not that I'm excited for Nick to come in and share his expertise. I know he's got a possible surprise for our members, which I'm excited to hear about. But I'm looking forward to it. It's kind of been one of those things, mainly out of just busy life, sheer probably intellectual laziness to not really do the deep dive on it that it needs to determine where it fits in my practice. But that's why we'll have Nick in to help us figure that all out and figure out where it might fit in your practice and give us some clinical pearls. But anyway, before we drone on about that, Jarod, this episode we left off last time talking about lower extremity neurodynamics and also talking about dosing. So we've gotten into some of the things around the upper extremity and diagnoses that sometimes can be looked at as very local tendinopathy or tissue issues that probably need a little bit more exploration and a little bit more clinical reasoning and thorough examination incorporating neurodynamics to really determine what the totality of what's going on in that situation may be for each individual patient. What about lower extremity for you? Like, what kind of things are you seeing from the lower extremity perspective when it comes to neurodynamics? Maybe some areas that, man, we usually traditionally, before really incorporating neurodynamics, might have just looked at it very peripherally, strictly without consideration. Anything that comes to mind for you?
Well, I mean, when I think about neurodynamics for the lower extremity, it's always a piece of my examination for anybody that presents with low back pain, hip pain, posterior, lateral, or anterior thigh pain, knee pain, calf pain, ankle pain, foot pain, right? Because that is the path of all of the sciatic and the femoral nerves. And we know that lumbar spine related issues they're the most common musculoskeletal complaint that we deal with. So I always start from the spine and work away just to make sure that I'm not missing anything and try to be really consistent about that. And a neurodynamic assessment through both the slump and the straight leg raise test and potentially the femoral nerve tension test, they're pretty much always a part of my evaluation process just because there are so many things that can present similarly from IT band like type syndrome to lateral knee pain from maybe a neurological cause, or you get I can't tell you, literally hundreds of times I've probably gotten a referral that says hamstring strain, and it's somebody, excuse me, it's somebody that's been dealing with a hamstring strain for 2 years. It's like, well, I don't think your hamstring strain is hanging around for 2 years, or your calf strain has been there for 6 months. So I think that it's just it's something that's always integrated into my assessment for the lower quarter.
Yeah, I actually have two folks right now. I have strangely a DPT student. Before we've gotten a hold of him and really got to talk about some of this clinical reasoning and stuff, but I think he's a first year or second year actually. But anyway, came in yesterday with low back, and he said, I also got this hamstring strain that I've had for 2 weeks. And then I talked to him like, well, what's your mechanism of injury? Well, I don't really have one. It just started. I'm like, okay, let's unpack that. So we had a little clinical teaching moment there as far as, okay, what is that? Let's look big picture. And he's got like a 30-degree straight leg raise with, kind of lights up with dorsiflexion. And then also have some patients, because we work closely with a podiatry group. We have a podiatry program at Midwestern University where I practice, and frequently we'll get kind of the local foot specific treatments. They do amazing stuff there at the podiatry clinic, and they're some great practitioners. But I often get their cases that it ain't happening with like very localized stuff. So I have a patient right now who she's got burning symptoms in the heel, pain with prolonged walking. She also got a history of low back pain with a discectomy, laminectomy 2-3 years ago, and they've been doing everything you can think of for local treatment at the foot. But again, you do some straight leg raise. It's significantly limited on that side. She's got lumbar, and she's a good example. She's like, gosh, she is not moving. She's also got a lot of whoever did her surgery did not educate her well. Maybe they tried and it just didn't sink in. So I'm not going to assume, because I know sometimes our perceptions of what happens from an encounter isn't maybe the reality of it, but she's just petrified to move her back. She's like, I can't rotate my back. I'm like, you can't rotate your back. And so we've been unpacking that a little bit, getting her confident in her back again. But, burning pain in the foot. And is it the back? Is it the foot? Man, she's got straight leg raised. Looks like it. So I again defaulted to let's load the back and see if it changes your foot. And lo and behold, her retest of, hey, how does it feel walking? She does some, a good dose of repeated extensions, and walking significantly better as far as feels better. So we've been kind of connecting the dots for her, and she's doing a lot better. She's going back to work this week after, an 8-month, pretty debilitating, depressing. She's really come a long way just from a psychological standpoint, because she's had to unpack a lot of her work defines her, and that kind of was taken away from her. So she was, struggling with that. But yeah, I think I would echo what you said, Jarod. Is straight leg raise, slump. If anybody that's got lower extremity things, I think just due diligence. You're not only should your exam from a physical exam, but your questioning should be up the chain a little bit. Any history of low back issues for you? Any history of low back where you had some radiating into the leg? How about other symptoms you have? Because these folks with Achilles pain, heel pain, medial ankle pain, posterior knee pain. You start unpacking these things and you start thoroughly questioning any symptoms going below, anything going up to, we're all questioning all the way centrally to the spine, currently or in the past symptoms, and you might find that, gosh, there's dots connecting here that looks like there's a spotty referral of maybe what could be a neuropathic pain component of what they're dealing with, and just being thorough and not missing that stuff. And again, stuff we hammer to our mentees in the Supercharged group. He's like, you gotta be thorough, and you gotta have a process that's repeatable. But what's been your experience with kind of the thoroughness, not only in the physical exam, but also maybe the patient interview?
Oh man, it's the ags and eases for sure, right? I think that these are not focused on enough. But when you start really asking somebody, what makes that hamstring strain worse? Oh, dude, when I sit for 30 minutes, that hamstring strain really kills me. And it's like, well, that's funny. You're not using a hamstring and it's in a shortened and relaxed position and it starts hurting, or that posterior knee pain, that Baker's cyst becomes incredibly full and crampy and pressure filled and like starts tingling a little bit when you sit for 30 minutes. Oh, that doesn't sound like a Baker's cyst, right? So you're really digging into the things that aggravate it or the things that ease it. Oh, when I stand up and walk, when I've been standing and walking for a while, my my hamstring strain or my calf strain feels a lot better. It doesn't bother me so much, or vice versa, right? So you start to see how symptoms are affected by activities, and you can make a lot of sense. You can do a lot of sense making of, well, if this was a connective tissue, if this was a contractile tissue, it probably wouldn't be affected by this. I'm seeing that there's a difference in the lumbar spine position. I'm seeing that there's a difference in, maybe disc loading, or I'm seeing that there's a difference in X, Y, and Z in their symptoms that doesn't necessarily add up to what that diagnosis is. And that's to me where it has to start, is really diving a lot after you've gone through, hearing the person's story, and after you've gone through, kind of making a connection with them and letting them speak. You start diving into some of those ags and eases, and then kind of your severity and irritability, right? So some of the stuff from like the Maitland SENS approach. Well, how severe is this? How long? How intense is it? Is it debilitating, or is it just a little bit? How irritable is it? Does it get really pissed off with any amount of movement or load, or does it take a while to get irritable? Do you have to load it a lot before it shows up? What's the nature? What does this feel like to you? What is it? Is it crampy, or is it a sharp pain, or is it achy, or does it kind of burn? Does it sting? Is it tingly? Is it numb? Like, you can get these words from people, and you try not to lead them. You try not to put words in their mouth, right? But you can get this kind of quality of what they're feeling that might lead you kind of away or towards a certain thought process when you correlate that with everything else that you're getting from them. I would never take that in isolation, right? So you start asking all these questions, and you get a really good idea of, well, what the diagnosis was, or what it says on the referral thing, or what they think that they have isn't really jiving. And then that's going to lead you down a lot of your assessment from there, right? So you should have your assessment dialed into the things that you really want to look at before you ever put your hands on that person, because you've done such a good job of getting that information from them and listening to them very intently.
Yeah, you should feel like you've really exhausted all the questions you can ask just from an interview perspective, where now it becomes I need information that I can only ask through physical examinations skills. Now, obviously, you're going to miss questions, and the crazy thing is your interview can continue into the examination where, oh yeah, I forgot this question. Let me pop that at you while I'm doing it. And then you're right. I think the quality of the symptoms, like these patients that I'm seeing recently with some neurodynamic components, a lot burning, stinging, ripping, where it's this just kind of sharp kind of line of discomfort that just doesn't always jive for the typical tendinopathy or typical things. And again, it doesn't make its decision on its own, because you got to be thorough, like Jarod said. That this one quality of symptoms report isn't going to make the diagnosis for you. But if you start hearing, God, it's burning, it's stinging, it's kind of radiating down, it's not really focal at that tendon, and you can trace sensitivity when you're doing palpatory things. That's why it's helpful to do some nerve trunk palpations and determine sensitivity differences side to side on some of these things to see if the things are lining up to really support a hypothesis that there's a neurodynamic component there. But yeah, you got to keep that hypothetical deductive, that funnel wide initially, and your questioning should narrow it, and then your exam should at least, keep some of those things in line. To at least minimum, you check the box. Yeah, it doesn't look like there's anything going on here. But remember, neurodynamics, the big mistake people make too is that they think if it doesn't reproduce their exact symptoms, it isn't positive. But that's where if you see somebody's got like a 90-degree straight leg raise, and on the affected extremity, whether it be a heel, posterior knee, or whatever, it's 45, doesn't really reproduce their exact symptoms, but man, it's significantly limited, or different sensory responses, like where one's just a stretch, the other one's like, oh man, it's burning down the back of my leg and my hamstring area. Those are things where you think about, hey, there's a difference in range of motion, there's a difference in resistance of that test, there's a difference in sensory response to that test, which would just, again, would make you think that, hey, neurodynamics remain on the table. Again, those things, just that on its own, of course, doesn't really make the diagnosis itself, like we said. But yeah, it's looking broadly and never zeroing in on the extremity, because you're going to get prescriptions from physicians and well-respected physicians who the podiatry folks, that's their bias, and that's okay. I think they'd own it, that they look at things very much through a foot-centric way of diagnosing, and our job is to cast a wider net when things aren't working with that. And that's where you should be thinking, yes, this is the diagnosis that I'm getting, so this framing bias that you get, because you're going to get the diagnosis framed to you often by the physician. And then I always tell students, heaven forbid you use your degree that you're spending a few bucks on and you're stressing your brains out and working your butts off to get, that you use your degree and determine, is that in fact what I'm seeing here with my expert eyes, with my good musculoskeletal expertise that we hold as physiotherapists and chiropractors, other folks out there. Yeah, it's just make sure that it fits, and not just zero. You're not treating the diagnosis until you validate it in clinic. Not that, because I can't tell you how many people, as I've already mentioned, posterior knee pain. Jarod said his hamstring strained and stuff. If you just treat diagnoses, you'll be rubbing on sore spots that are something that sore there from a much more bigger picture issue that you're missing the boat on if you don't really have a consistent process that you're going through. Any other kind of clinical things you think would be worth folks thinking about, or maybe pearls that you would want to share for folks around lower extremity, Jarod?
Yeah, there's a couple things that I thought about when you were talking, and one is, when you're doing that straight leg raise assessment or that slump assessment, if the person that you're evaluating is lower irritability, this is why it's really important to keep irritability in mind. If there's somebody that their symptoms don't come on for 20 or 30 or 40 minutes or 3 hours of activity or whatever it is, right, or a long period of sitting, and you do that straight leg raise or you do that slump test, you might not get a big symptom presentation, but you might get a difference in movement excursion side to side, right? Like you mentioned. And it's worth keeping in mind that you might not get the traditional positive test of recreation of their pain, but, excuse me, had to clear my throat, having a little bit of allergies and stuff like that going on this morning, so I apologize. But if you maybe do something that exacerbates their symptoms a little bit within reason, right? So maybe this person says, ooh, if I stand up and if I bend backwards 10 times, it like lights my symptoms up, or if I stay standing for a while. Well, maybe you might want to do one of their aggravating factors and then assess that test to see if your test is actually a little bit more positive once their symptoms are talking. Or if they say, oh, sitting gets it, it's like, well, you save that slump test until the end, and maybe you have them do a few repeated forward flexions, and maybe you actually apply a little bit of external load as well, to their back when they go into that slump position, because it's low irritability. They've already told you they have to sit for 30 or 40 or 50 minutes before their symptoms come on. So you want to try to exacerbate their symptoms just a little bit, not a ton, but just a little bit, to actually see if that test that assesses the neurodynamic component is positive under the circumstances for which they usually have pain. And I consistently see students not think that way, not recognize, oh, this is a lower irritability condition, because when things are highly irritable, it's super easy to see. You put any load on somebody on a straight leg raise test, and it just lights them up like crazy. And you're like, oh yeah, that's positive. That's really easy. But when it's a little bit more nuanced, and somebody's maybe been dealing with this for a while, and it's just gotten to the point where it's kind of residual neural sensitivity, or an impaired ability to tolerate their normal amount of load that maybe a completely healthy nerve would, then you've got to be a little bit more specific and nuanced in how you go about doing those tests to get good, clear answers, or to get better answers anyway.
Yeah, and that's, again, knowing your patient, qualifying their symptoms. That's where we use that symptom behavior model. And I know I've been on social media recently saying you should not have two different evaluations. Like, to me, you open yourself up for massive diagnostic error. I mean, you need to have an evaluation that can pivot and move to the unique human in front of you and not any preconceived, this is my pain evaluation, this is my normal evaluation, because again, but that's a whole nother discussion, gets us frustrated. Maybe we'll have an episode on that, like, do you need 2 evaluations in PT? But yeah, it's knowing that, hey, if I have low irritability, it gives me the green light to start kind of getting after some symptoms and bringing them out, because I know, oftentimes those folks have symptoms that they tell, yeah, just, if I sit for 5 minutes, I'm fine, doesn't really linger too much, or they have a really easing factor that often is pretty easy. So you have, some slack they've given you to kind of play with their symptoms a little bit, instead of the highly irritable folks where you're probably not going to have much issue, eliciting symptoms. And then some of these folks take, static loads for 30, 40 minutes, like Jarod said, before symptoms emerge. And then you may not be able to get to those in clinic too, but you can also have the patient test things at home in the presence of their symptoms. It's a frequent thing I'll do, is like, hey, I don't have an hour for you to sit and find these symptoms, or an hour for you to walk or things, but when they do occur, here's what I want you to do, and I want you to test some things for me. And most folks are like, oh yeah, I'm on board with that. I want to figure this out too. So if you kind of pose it like, hey, we're in this together, we're going to figure this out, but I need you to do some things for me to kind of help me guide my thinking on this. I haven't met any patients that have been, no, I'm not doing that. That's ridiculous. I don't want to learn more about what's going on with me. So yeah, I think it's one of those things where, just knowing the patient and their unique presentation, and knowing how much you have or don't have as far as leeway to start playing with symptoms. But that's what makes clinic fun, because everybody's different. Every patient that comes in your door is different in that respect, oftentimes, where one patient, you're really dancing gently around symptoms and moving just to edges of things. Other patients, like, let's get after it, let's find it, let's load this thing till we see what's going on. I know I saw a social media post is like, if the patient's symptoms only get brought on with heavy loads, you're probably going to have to find a way to bring some heavy loads into their treatment or assessment, even to figure out if you're making change or not. I mean, but we still get these folks just pumping like 5-pound dumbbells around and thinking we're and again, we've had a massive underdosing issue in our profession, which we'll probably talk about more as well. But yeah, I don't know if I have any other tidbits to share on the neurodynamic front. How about you, Jarod?
I've got one thing, man, and we talked about this in the upper extremity neurodynamic episodes, but it's just how important it is to be consistent with how you actually conduct these neurodynamic assessments, and being very sequential in the components that you use. So for the straight leg raise test, for instance, I use the hip as the component, right? So you maximally dorsiflex and all of that sort of stuff, and you hold the knee in extension, and then your movement axis is the hip. So you're measuring hip flexion, and you always start with the non-involved side, so the patient can know what a normal test feels like, and then they can know what a non-normal test, or what the test on the non-involved side feels like. So it's very purposeful, and it's very sequential, and it's really repeatable, right? And then, you can add in head components, and you can add in different things. You can have them change their head position. You can let off of their toe. And my favorite question to ask people when I'm doing a straight leg raise test, and I let off their toe, and I say, does that feel better? And they say, oh my God, that feels so much better. And I say, well, what's the only thing connecting your toe to your hip? Because I'm moving your hip right now, and I let your toe go, and all of a sudden it feels better. And that's a light bulb moment for people. They're like, well, my hamstring doesn't go to my toe, and I thought I had a hamstring strain. So then it becomes, your test becomes the perfect teaching moment for that person. And then I think it's important to recognize that a straight leg raise test typically tests somebody more in anterior pelvic tilt, or something more similar to standing upright or extension, whereas a slump test tests somebody in flexion. So if you have somebody that flexion feels great for their symptoms and extension feels bad for their symptoms, a slump test might not be as positive as you think it might be, because they're going into their position of relief, and then you're testing their nerve there, and it might not be as positive as you find them to be on a straight leg raise test, or a straight leg raise test that's even biased towards a little bit more extension. You could have a pillow underneath their back biasing them towards more lumbar extension, or you could do a straight leg raise with them lying on their side where they're biased towards extension as well, and you might get a totally different test result if you're biasing the lumbar spine towards or away whatever directional preference they might have.
It's good points. Very good points. Yeah, I think having that creativity in clinic and thinking of, understanding that, hey, slump also loaded versus unloaded. You don't have, the person's laying with unloaded spine versus sitting with loaded spine. One obviously more biased towards extension, one biased more towards flexion. And then you can start playing with positioning spines in different positions as you're adding these tests and seeing, does it change things and does it maybe bring out things that weren't there in certain, like Jarod said, thinking about directional preference and things. Other kind of pearls I would definitely recommend folks with lower extremity neurodynamics. You need to know how to bias your posterior tibs, your peroneal nerves, your sural nerve type things, because sural nerve often traveling right along the Achilles tendon, which can kind of, if you can bias that through dorsiflexion and inversion, and then your posterior tib, your dorsiflexion eversion, and then your peroneal plantar flexion inversions, where you're kind of loading those directions at the ankle and then lifting a straight leg raise up and seeing if you're finding any specific symptoms on that route. But that's where you start being able to, especially your plantar fasciitis with posterior tibial nerve. And then this patient I have right now who I spoke about, she's got what they call tarsal tunnel syndrome, which again, posterior tib nerve kind of entrapped in that or medial ankle. I think it's more her spine that's got things going on, but she's got some definite posterior tib nerve sensitivity, which that diagnosis I don't think is a bad thing by any means, because I think it definitely talks about neural sensitivity there. I just think they, again, at the podiatry front, don't move much above the ankle to think through that whole reasoning process, which is fine. That's that's where we can come in and help the team out and help folks, most importantly, help patients. So anyway, so if this is something where, hey, if you're finding value in these episodes, we've had some great feedback with the Clinical Pearl episodes that we've been kind of focusing on. This is exactly the stuff that we're focusing on in our Complete Clinician Supercharged group as we're coaching folks in their practice. Jarod and I are taking on a limited amount of folks to do coaching with, to where you learn in your practice, because I think Jarod and I both would agree that weekend courses, online courses are fine, nothing wrong with them, but then what happens when you're in a clinic and you face a case that just doesn't make sense, or you want to talk through these neurodynamics or issues like that? That's what that program's all about. So take a look at it. You can jump on a call with Jarod or I, and we can talk about to see where you're at in your practice, what problems you're having. We can give you some game plans of how you can move forward. And then if it makes sense and you feel like it's a good fit for you to work with us, we can talk about what that would look like to see if it's something that would help you in your practice. But Jarod and I have just come to the point where we realize that if we're going to make the impact in people's practices, and not all of us can go jump and move for a residency or fork over the cash for a fellowship or residency, which you need some resources, you need some options to sharpen your game. And we've had a great time with our mentees so far, really having some fun conversations and had some good feedback so far. But if you want to jump in and check it out, jump in modernpaincare.com/supercharged, and you can check out the program and jump on a call with Jarod and I, and we'll go through it with you and see where you're at. Anything you want to add to today's episode, Jarod, before we finish up?
No, I just I want to invite people to come back for the next episode where we actually talk about dosing.
Yeah, we will actually talk about dosing, and then we'll get into more deep depths of neurodynamics and maybe dosing around more things than just neurodynamics. I think we'll tie this into kind of the patient symptom behavior model and how that might all connect the dots on how to better dose with things. So until next time, you guys have a good rest of your day. We'll talk to you soon.